Hello, everyone, and welcome to tonight's webinar, What to Know About Obesity Medications and Uterine Cancer Recurrence. I'm Kitty Silverman, Uterine Cancer Program Director at SHARE. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecologic cancer and provides outreach to the general public about signs and symptoms. For more information about our upcoming webinars, support groups, and helplines, please visit our website at sharecancersupport.org. We're very excited to have Dr. Michael Garcia joining us as today's speaker. And now I'd like to hand it over to Dr. Garcia to introduce himself.
Thank you, Ms. Silverman. Good afternoon, everyone. Good evening for those joining on the East Coast. I'm an East Coaster myself, born and raised in Maryland. So glad to speak to everyone tonight. Thanks everyone for joining us. My name is Michael Garcia. I have been practicing medical nutrition for about 6 years now. I'm actually an internist trained in internal medicine with a subsequent focus in medical nutrition. So I actually kind of spans the full spectrum of nutrition from, I call it undernutrition to overnutrition and everything in between. So part of my goal is to really help, hopefully many of you navigate this important topic. And I know there's a lot of information out there. So part of my goal, and then I hope to stimulate a lively discussion towards the end. So it'll seem a little bit lecture-like, but hopefully we can have some good discussion at the end. So glad to be joining everyone. Thanks for tuning in. What to know about obesity medications and uterine cancer recurrence. So wanted to just present these points just so everyone knows what to expect from tonight. We can definitely go into more than this. But describing obesity as a risk factor specific to uterine cancer, a little bit about the background of nutrition oncology, what that means, and then really delving into the history of current and then near future pharmacologic treatment that we have for obesity in the context of uterine cancer recurrence and why they're important when taken both together. And then, like I mentioned a little bit ago, hopefully this can help everyone navigate the information out there to some extent, depending on your specific situation. So want to just very briefly define obesity. There's a lot out there today about body mass index, obesity. What's actually unique is we still use these BMI, body mass index categories to define obesity. Obesity is really better defined as excess adiposity. So body mass index alone does not define it, even though it's easy to do at any sort of visit with any of your practitioners. Everything you read, it's based off of these categories here. So I don't want to get too much into sort of that classification, but this is the traditional classification. You can see on the right-hand side how they're classified. We do need to take into account everyone's individual characteristics, which are important: age, gender, ethnicity, if someone has any condition that may lead to swelling, different amounts of muscularity. Depending on ethnicity too, we know that there are certain revised cutoff marks when we can see excess fat tissue, which is excess adiposity, as you see here. Anyone of South Asian, Southeast Asian, East Asian descent, and then anyone in the Latinx or African American population, we know that their obesity and metabolic conditions, things like diabetes, fatty liver, high cholesterol, disproportionately affect some of these populations. We also use waist circumference as an additional measure, not the only thing we may do during a clinic visit, but again, we need to be aware of different cutoffs. These are general markers, but also sort of a complementary measurement that we can use as well. So why is BMI, body mass index, uterine cancer, why are they important, and why are we kind of even talking about this topic? Well, they've done a number of review articles where they take collection of many, many different studies, and they look at the association between body mass index and uterine cancer incidence. So any first diagnosis of uterine cancer. You see at the top of the list here that That box, the gray box, is just to the right of the vertical dotted line. So we know that there's an increased risk with elevated BMI. That middle category where it says overweight, we see an increased risk 1.55, anything above 1 for that HR stands for hazard ratio, constitutes increased risk. And then on the right hand side, you see obesity. That's an even higher hazard ratio. So we know that there is an association between the two. It doesn't imply causative, meaning if you have an elevated BMI that you will necessarily be diagnosed with uterine cancer. Again, it's just an association that they've seen. Here we see different types of uterine cancer as well. You can see on the left-hand side, it kind of breaks down the body mass index category, and you can see with increasing body mass index, there's an increasing OR stands for odds ratio, kind of similar, but increased risk at each body mass index category above sort of 25, which is considered, I'll say, quote unquote, normal, because there are exceptions to that. But that's to sort of present why it's important, why we're talking about this topic. It's even more important because we know that really with every year that passes, specifically in this country, that body mass index incidence of overweight and obesity is just growing year by year. We know that 42% meet that criteria for obesity based on the body mass index cutoff. This was as of 2020, so that's even increased now as of 2024. We know the medical costs are very, very high, to say the least. This includes treatment of certain malignancies, including uterine cancer. This actually applies to every race, ethnicity, depending how you classify things. So this is the overall incidence of obesity, but it applies to everyone across the board. Nutrition oncology, I want to just give you a brief taste and then really kind of jump into a little bit more specific about uterine cancer. But nutrition oncology is a very large umbrella, and it encompasses, when we think of different nutrients, so different vitamins, different minerals, fiber, protein, things like that, and its relation to either protection against cancer, increased risk of developing cancer. Then we kind of get into the full food sources, any full or whole fruits and vegetables, anything that comes in a package, macronutrients, that's where the protein, fat, carbohydrate come into play. And then we like to think actually even more so and a little bit more effectively into what we call nutritional intake patterns. So not just are you having this individual food, but are you pairing it with other good individual foods, or is your overall nutritional intake pattern not ideal, but you're incorporating carrots every day, for example? So the intake pattern is really much more important, much more lends itself to what our bodies are exposed to on a day-to-day, week, month, yearly, sort of chronic basis. And so that's why it's more important. This is a very busy slide, so I apologize, but reason I wanted to present it to you is they've actually done some computer-generated models in terms of what constitutes a healthier intake pattern and maybe not so healthy. And these were all based off questionnaires of individuals like you and I into what they eat on a day-to-day basis. So you can see red and blue lines, just the squiggly lines. The red kind of encompasses what we would commonly refer to as that less healthy nutritional intake pattern. You can see a propensity towards things like potato chips, snacks, dipping sauces, certain plant oils as kind of more prevalent. Some potatoes, processed meat. The healthier, the blue one, higher amounts of legumes, so lentils, edamame, soy products, vegetable soup, cooked vegetables, raw vegetables. And I didn't want to present this slide because there are a lot of different cancer types that they've looked at. And they looked at many, many different nutritional intake patterns, some of which you probably have heard of: Mediterranean pattern, low carb, healthy eating index that kind of plays into this computer generated pattern as well. But they've looked at associations. So, not necessarily new information, but what we know, which is constant or more chronic exposure to healthier foods and a healthier pattern is better for our body in terms of reducing risk of many chronic diseases or improving the status of those diseases or helping to prevent recurrence, and that includes many different types of cancers. So over 50 plus years, there every so many years, every 5 to 10 years, the general consensus recommendations for cancer prevention, and these are extrapolated to include during treatment and when someone's sort of post treatment. These are the recommendations, and they really haven't changed to a large degree. None of them are anything brand new, but we always need to remind ourselves of these. So, especially with uterine cancer, be at a healthy weight. Again, that's body mass index. And I should say that comes with caveats depending on your individual characteristics, but being physically active, are we getting whole grains, vegetables, fruits, beans, limiting fast food, other processed foods that are high in fat, starches, concentrated sugars? Are we limiting sugar sweetened beverages and limiting red and processed meats, limiting alcohol? More and more, yes, while there historically have been some benefits to alcohol consumption, overall, a lot of the professional societies really moving towards less is more. Not necessarily using supplements for cancer prevention. If you are a mother, breastfeeding, if you can, after a diagnosis, following all of these recommendations, being consistent with all of these recommendations. Why weight loss is important. We know a number of different benefits. We see here the percentages on the right, that's actually the percent weight loss from anyone's starting weight. So we start to see some improvements in these conditions listed here. A lot of the improvements start at 5%. So I commonly am asked, well, how much weight do I need to lose? I used to be this weight in my 20s or 30s. Now I'm 50, 60 pounds higher than that. Do I really need to get back to that previous weight, or how much weight should I lose? Well, the answer is it really, we see a lot of benefit in small increments. So a lot of improvement at 5%. So if you're 200 pounds, that's 10 pounds. It may not seem like a lot initially, but we, in some of these markers and quality of life scores, we really see a lot of benefit. And then with each percentage above 5%, 10%, we see further improvement that includes at 15+% improvement in what we call all-cause mortality, depending on the underlying risk factor. So this is just a general algorithm when we approach what we call weight management. So we have a lot of people refer to us for elevated BMI. That does not necessarily imply excess fat tissue. It may. We generally see a correlation. So if your body mass index is above that 25, that normal range, it may or may not mean you have excess fat tissue. But in general, this is how we approach anyone who comes to us with elevated BMI, right? So the staple of all of this is nutrition modification, physical activity within someone's constraints, behavior modification, and that behavior modification incorporates nutrition, physical activity, but also sleep, stress, any other really hurdles that prevent maintaining a healthy weight. The next step is pharmacotherapy, and that's what we're really going to jump into. But there are certain individuals that may or may not qualify for medication therapy in addition to that foundation of nutrition, physical activity, behavior modification. I present surgery here just because it's part of our algorithm and what we may consider for the right individual. But medication wise, I want to jump in and really spend the rest of the time that I'm talking focusing on that, what the options are, what the future holds in terms of medication. So these are the individuals that qualify for medication. The societies still don't take into account those ethnic differences, but we need to take that into account depending on the person in front of us. So if someone has BMI elevated above 25, those foundational steps, we do that regardless. If their body mass index is over 27 with a weight related condition like diabetes, high cholesterol, high blood pressure, we can consider medication. Or if your body mass index is greater than or equal to 30 on its own. These are all of the different medications we frequently will use or consider. So left-hand side is more important to pay attention to. These are the ones that are FDA approved. In red, those are the ones FDA approved for long-term use, long-term meaning greater than 3 months. Phentermine at the top, some of you may have heard of, that's technically only approved for 3 months of use. Because it's been around for so long, they did not do particular studies evaluating it beyond 3 months. So that's why it's not approved beyond 3 months. But not to say it cannot necessarily be used in that way as long as closely monitored. The right-hand side, again, I don't want to flood you with a whole bunch of names, but other medications that we may use in conjunction with the left-hand side, or depending on other conditions you may have, these are also used and they do have some sort of weight effect. So in green, those are the ones we use in type 2 diabetes or elevated blood sugar. In purple, those are used for anyone with a history of seizure and or headache history. Bupropion, also called Wellbutrin, we use that for depression or smoking cessation. Naltrexone we use for alcohol use disorder. So not directly something we would start for the primary purpose of weight management, but they can have a weight effect. So very briefly about the timeline, I'm going to give you all the names here just because the reason I'm presenting this is just to show you still how young it is in terms of the timeline for approved medications for weight loss. So for many, many years, 40 years, all we had was phentermine, the oldest, very effective appetite suppressant. At the bottom, those are the ones that are now, they've been taken off the market due to various side effects. There was a medication called fenfluramine with an F, was paired with phentermine, but it had some cardiovascular side effects. So that piece is taken off the market. The phentermine is still available. But then you see 1999, something called orlistat, which we'll go through. And then really in the last 10, 12 years is when majority of things have been approved, and really half of those within the last 3 years. So phentermine topiramate, we'll go over all of these. 2014, 2 medications were approved. And then in 2021, semaglutide is Wegovy, and then just most recently Zepbound, or the generic name is tirzepatide. So all of these medications work in some way on appetite and satiety. Satiety is that feeling of fullness we get after a meal. So right after a meal, our body should prevent further intake. We should feel that satiety or the satiation. Not everyone feels it to the same degree. But the left-hand side, right-hand side, there's been in the remote past some testing of how do we increase metabolism. We hear that term a lot. And they tried it with things that affect our biological mechanisms in very severe ways. And ultimately, certain things are affected to such a degree that they can lead to death. So increasing metabolism, how we think of it classically, is not something that's safe to do. Others actually do decrease energy absorption. So we'll go through this, but there's a medication where we don't absorb fat. There's another one that's used for diabetes that we do not absorb glucose. But most of them work on appetite, satiety. All of them work in some way, at least partially, centrally in our central nervous system. And there are a lot of different components of how our brain processes hunger cues and cues that make us feel full. There is what we call homeostasis. So trying to really maintain the status quo. We take in energy, we expend energy. We got to maintain a balance with that. That reward center on the right, that plays a huge role in everyone to a different degree. It's not just about our desire for something and then acting on that desire. There's a lot of biological mechanisms when we see something or smell something, or if we're tired, that reward center really starts to act in a way we don't really have much control over. But we know that's involved in feeling of hunger and intake and feelings of fullness. And then cognition, that's of course part of the central nervous system as well. But the brain is releasing different chemicals to try to stay into balance. The good and bad thing is we don't have complete control, really not much control over the release of those signals. That just happens without our saying, okay, or saying to stop that release. So these are the medications I presented on that timeline slide. Going to go through a few of these a little bit quicker, but orlistat still available. It's also available actually over the counter as well. If any of you have heard of Ally, ALLI, that's what orlistat is. So basically, it prevents our body from absorbing fat. So if we eat anything higher in fat, our body's not going to absorb it. Likely, we will have increased flatulence, maybe diarrhea, maybe fatty stool. We are at risk for not absorbing certain vitamins, but we're basically malabsorbing calories specific to fat. So it can be helpful. I wanted to present the graph on the left hand side that shows the percentage of weight change versus in red versus the gray or black lines. That's what we call placebo, so without the medication. So close to 11% over about a year in the initial study they did in the early 2000s. But when we think of what we call relevant weight loss, or at least 5% from that starting point, only about 35% of individuals taking this reached that cutoff. So effective. Typically what we see is the side effects preclude long-term use, even though it is approved for long-term use. So helpful, but usually not well tolerated. Phentermine, I mentioned, the oldest appetite suppressant. It works in a similar way to any stimulants that any of you have heard of. It's what we call sympathomimetic amine. So it activates our sympathetic nervous system, and it acts on certain receptors in our brain to inhibit feeding. So it's an appetite suppressant. Because it's in the stimulant class, we see anything in terms of those increase in symptoms like increased heart rate, blood pressure. It can affect sleep, cause anxiety, cause us to feel restless. We see dry mouth quite a bit as well. Pretty good results, and we actually see that carry into now. The initial studies they did, like I mentioned, were just 3 months, but we saw a good amount of weight loss, close to about 10%, and this was just over 3 months. So they haven't done studies on phentermine similar to a lot of these other medications, which the studies are about 12 months, so about a year, but good results after 3 months. Pretty well tolerated, of course, depending on your underlying conditions. Something we still use frequently today. Of course, I should mention all of these medications, there are reasons we can and cannot consider giving them, and that's always something that should be evaluated depending on the individual that may be prescribing these for you. Right-hand side, various doses for the phentermine, just so you're aware of. So there's quite a bit of variation in terms of how we can tailor that. Phentermine's also more recently in the last 10 years or so been paired with something called topiramate. Topiramate on its own used for headache prevention, if any of you have migraines. It can also be used if someone has a history of seizures. It's one of the options there, but together they each actually have an effect on appetite. So when paired, they both work slightly different ways, both affecting appetite in different ways. So a lot of sort of jargon here, but that point about inhibitory effect on NPY/AGRP, that's one of the areas in our brain at least one of the areas that we think affects appetite. And so anytime we eat or following eating, there's a feedback mechanism essentially that prevents us from eating more. So many of the mechanisms decrease intake and work to prevent further intake of energy calories. This does this to a kind of a larger degree. So it makes sure that that mechanism, that feedback mechanism is active. Similarly, as phentermine alone, similar potential side effects as well. Topiramate on its own can cause a little bit of drowsiness. And so when it's paired with phentermine, we typically don't see that. This is approved as a brand name medication. Sometimes we may give them separately depending on everyone's favorite, which is insurance coverage, or I should say everyone's least favorite hurdle. But it is something that we could give separately in similar doses. The results were pretty good. So over about a year, we saw close to 9 to 10.5% weight loss from that starting weight. And close to 3/4 of individuals in this particular study saw that reached that 5% target cutoff that we think of as effective weight loss. So orlistat about a third, phentermine topiramate close to 3/4. And this just presents that in graph form. You can see they actually did do what we call an extension study. They did it for a little over 2 years, and majority of that weight lost was maintained. You can see a slight uptick on those two bottom lines there, but overall it was maintained a little after 2 years. That top line is no medication. Naltrexone and bupropion, the brand name is Contrave for that. This works in a slightly different way in our central nervous system. Still works on hormones that our body and our brain releases. One of them, naltrexone, it works on the opioid receptor. One of the thoughts when this first came out was if someone has a little bit more of a component of that reward center causing weight, difficulty with weight, or if someone maybe has a larger component of emotional eating, which we all do to some degree, maybe this is particularly more effective. I'll explain in a second. May or may not be the case. This is pretty good. I'll show you the results on the next slide, but of course, like with everything, some adverse effects we can see that you see listed here. So it requires close monitoring. The results were pretty good. After close to a year, we saw anywhere from about 6.5 to 8.5% weight loss from the starting weight. The green line in the triangles, that was on the higher dose. So the highest dose that we typically try to make our way to after about a month or 5 weeks. Overall, though, in terms of percentages, not quite as good as the previous medication that I mentioned. So about 6.5 when it was taken through beyond a year. So only about half of individuals reached that 5% of weight loss. The newer medications, which have been in the news that you probably have seen or heard about or read to some degree, they're all in the what we call the glucagon-like peptide receptor agonist class. So GLP-1, you'll probably hear that more often. But they basically, this compound, this protein is released in response to food intake. It increases our body's release of insulin. It decreases movement of our GI tract, specifically our stomach. So in that way, we feel full a little bit quicker than normal. It also has receptors in our brain, so it's working on appetite through our brain mechanism as well. The thing that is often not necessarily talked about is that receptors for this protein is pretty much in every organ system. And so it can have an effect on different organ systems. They're doing a little bit more research about how chronic exposure to these medications may or may not affect other organ systems. So just to be aware of kind of the mechanism that we're targeting when we give this for weight management, but may have other effects as well. So in bold, those are the 3 in this class that are approved, FDA approved for weight management. The last one is actually a combined medication with this protein along with a newer one, which we call GIP. I'll kind of briefly explain that. But just to be aware of reasons that we cannot give this medication, this specific class, there's a certain type of thyroid cancer that we need to evaluate if it runs in the family, any first degree relatives. There's something also called multiple endocrine neoplasia. It involves the thyroid gland, the pancreas, as well. And so there are certain conditions that we can't give that are involved in this multiple endocrine neoplasia. History of pancreatitis or inflammation of the pancreas or gallbladder disease or infection, stones, reasons that we need to be very cautious. Pancreatic cancer you may hear of as well if that runs in the family. That depending who you ask, we always proceed with extreme caution if that runs in the family. Pregnancy, like all of the other medications, and then because of how this works, we're always cautious about the side effects: nausea, vomiting, diarrhea, constipation, abdominal pain as well. Just to give you the results, to give you a sense of how they stack up against each other. So this was the first medication in this class that was approved. It's a daily injection right now, and it's actually still been on shortage from the manufacturer. So I would say we haven't used it quite as much because it's not available. But over close to 2.5 years, they did an extension study, anywhere from kind of 7 to 9% from starting weight. That bottom slide, which I didn't circle, but you can see about half of individuals met that 5% target cutoff when we think of 5% weight loss from starting weight. This is just in bar graph form. So a little bit over half reached that 5% in the initial study. The extension study I mentioned, maybe close to half continued or maintained that weight loss. The two medications that are now used on a weekly basis, semaglutide, which is Wegovy, we saw that in the initial study, which was 68 weeks, we saw quite a higher percentage of those that lost, close to 15% of weight from starting. So quite a bit higher than a lot of the previous medications. They're now doing and have come out with some studies looking at longer time periods. Is this weight actually maintained, or what happens after the 68 weeks? We do know, and this has also been in the news, we do know that if someone comes off of these medications, and it's really not unique to the injection medications, that we can see some weight gain. What I caution about this study and this graph actually is that it's not really how we use the medication in practice. So that yellow orange line, everyone in the study got the medication, and then they basically randomized, the top gray group stopped the medication, the bottom line, they continued the medication. In practice, if we need to come off a medication because of side effects, that's different. We might just stop it. But if there's a discussion with an individual and we decide together that, maybe after 2.5 years we want to come off, we usually wouldn't just stop the medication cold turkey. We would kind of gradually work our way down, like we gradually work our way up. And the purpose is, if we can prevent this increased risk of weight gain, of course, that's our goal. So really good results in this study. You can see the right-hand side, close to 90% reached that 5% cutoff. So quite a bit better than a lot of the previous medications. 15% total weight loss on average. That's average. What's important about the graph here, and I should have mentioned this with the other medications as well, you can see that, for example, 86% of individuals lost 5% from their starting weight. That means 13-14% of individuals didn't. So it's not effective for everyone. Fortunately, right now, we can't predict who may not respond to the medications, but whether it's with these injection medications or other medications, we do know that they're not 100%. And that goes with a lot of medications. There's not necessarily one medication that works 100% of the time. Tirzepatide, which is the brand name for the weight management medication, is Zepbound. Also really good results. A lot of information here, but the bar graph on the left, you can see with the different doses of this medication, close to 21% of weight that was lost from starting weight. And just at about 72 weeks, we see that 22% weight loss from baseline. close to 90%, so a little bit better than the semaglutide. 91% of individuals at the highest dose of the medication reached 5% of weight loss. Another caveat with all of these studies is the best results that are often presented, and especially presented in articles that are available to the public, it's at the highest doses. And I'll say in clinical practice, not many individuals have been able to reach the highest doses for a variety of reasons, side effects being a big one. Insurance coverage or availability is another big one. Is it not available for 1 or 2 months? Then we're kind of starting over. And so administration is a little bit scattered, something we have seen. So this is really, at least in the studies, the ideal scenario. So just kind of keeping that in mind if any of you have spoken about these medications with any of your other practitioners. So this takes all of the medications that we sort of have in terms of options, and you can see over time, because this really correlates with when these were approved, over time, we're getting better with those solid red bars in terms of the amount of weight that can be achieved with the medications. Again, with the foundation that there are nutritional modifications, physical activity, behavioral modifications as really the staple prior to and while we're giving the medications. So this is an important slide. We're making a lot of headway. As I mentioned, no medication is perfect, but I think at least we have several more options going forward. And again, kind of bringing it back in terms of uterine cancer, because we see that association with elevated BMI, these are going to be particularly helpful. Like with anything we do for weight, they're a tool. So it doesn't mean that they're absolutely required. They can be an important step for some individuals. They don't have to be a required step for everyone, but it is an option. And this just gives you a sense. There are a lot of different medications in the pipeline that they're doing research on. Some work in the brain to a degree. Some only work what we call peripheral tissues, whether it's in fat tissue, stomach, liver, GI tract, or combination of the two. But ultimately, like I mentioned, medications are one additional tool. We know that we would not just stop a medication cold turkey, like I mentioned, if we can help it. So you can see the green line there, that's sort of the effect in terms of weight loss that we see with non-medication interventions. A medication can potentially add to that. So they are cumulative. They're not just each individually important. We know that both are important together. This is a really old study, but it's all to kind of present that lowest light gray line there. We know that the most effective long-term sustained weight loss occurs with combination therapy, lifestyle, nutritional, physical activity. And then if someone is a candidate for medication, that could be medication for this alone. It could be for other conditions. For some people, surgery in the right setting. And then this is an important slide that I wanted to bring to your attention, because we are really starting to further individualize medication therapy, but also non-medication intervention. So weight and elevated body mass index for so long, and still in a lot of scenarios today, we thought just, okay, BMI is high, let's do the same dietary intervention, exercise more, that's working or that's not working, throw a medication. And for a while, everyone was kind of grouped into this same bucket. And we know not just with weight, but every condition, there's such variation. And this goes for uterine cancer as well, because there are different mutations, there are different receptors that are expressed. And so, as different cancer types and different subtypes need to be treated differently, right? For some, surgery is the first step. For others, chemotherapy. For others, monitoring or combination of the three. So we know with weight, that same individualized approach needs to be taken. This study actually grouped individuals with elevated BMI. So some people were grouped into what we call hungry brain. It's high volume at a meal. So you eat 2 plates, 3 plates, 4 plates before you feel full. Hungry gut is you feel full shortly after a meal. So you finish breakfast, 30 minutes later, you're hungry again, you feel like you need to snack. So that's hungry gut or a low level of satiety. Emotional hunger, again, which we all have, and there was some overlap. And then slow burn, the prototypical person over 65, postmenopausal, or short stature because metabolism is lower. And so metabolism is just low compared to other individuals. So they actually gave each group a different medication. And what they found was close to 98% of people in the targeted group achieved that 5% weight loss, which you saw that didn't, none of the other medication studies was that 98% matched. So this is really the direction we're moving in with medications. Can we further tailor type of physical activity? There are talks about, well, how do we further sort of individualize type of nutritional pattern, or should we say, oh, these 5 items you shouldn't have or you should have? We're not quite there yet with food, but we're working our way towards that. So body mass index, uterine cancer incidence, recurrence, we know there's an association, again, not causative, but we know that it's important to kind of be in those lower ranges. 5% of weight loss can be very, very beneficial. So everyone's goal, short term, long term, will be different, but just kind of keeping that in mind that 5% can make a big difference. We need to individualize it, whether that means considering medication, which medication. The goal ultimately with all of this is long term weight management. So I like to tell everyone, and I like to remind myself that as humans, we're not always built for patience. But for many of you, that doesn't mean, oh, if we lose weight in 6 months, that we're great, everything's fine. We want to make sure that we maintain it over 6 years and 60 years for some people. So that's always our goal when we consider medication, along with the other changes. And then I mentioned individualizing approach. So everyone's going to be a little bit different. That's kind of the challenge, but also the joy of all of this, that we all respond a little bit differently. And so there are many more options, and there are going to be more options in regard to this, and different strategies that we can use going forward.
So thank you so much, Dr. Garcia. It's wonderful to see that there is so much progress in this area, and a lot of it in really recent years. So we're going to start the Q&A. There were a bunch of pre-submitted questions, and you can still submit questions in the Q&A section at the bottom of your screen, and we'll try to get through as many as we can in our remaining time. So I'm going to start, Dr. Garcia. If you're taking Keytruda and Lenvima because of a recurrence, can you take an obesity medication? And if so, which one would be safest?
Yeah, you can, and a lot of the hormonal or sort of targeted medications, usually not a contraindication to taking these medications. Side effects would be the potential biggest thing, that they wouldn't necessarily interact, but just being aware, depending how someone is tolerating those two medications. And then, of course, any other contraindications or reasons we couldn't give the weight loss medications I presented. But it really kind of depends. The way, I didn't really mention this, but the way I approach considering medications is, first, are there any we kind of have to just put to the side because of conditions or other medications? And then from what we have available, kind of having a discussion. I think it's important to discuss with the patient, these are the side effects. If someone's afraid of needles, maybe we don't jump to an injection one. If someone has anxiety, maybe we don't jump to those. So it's really about the medications you're on, Keytruda, Lenvima. If you're doing well with those, you could consider really any of the other ones.
Great, thank you. I had a couple of questions to this effect. Are there any problems with using these meds and heart or high cholesterol issues? And there was somebody who wrote, and their doctor recommended that they not go on a weight loss drug because of high cholesterol.
Great question. The heart, you mentioned heart in the question. So I didn't specifically mention this. The stimulant medications, so phentermine, phentermine topiramate combination, and then the or bupropion naltrexone. Those three can all increase blood pressure, heart rate. Typically, if someone has a history of heart attack or they have coronary artery disease, sort of clogged arteries, or have had a stroke, those three medications we really shouldn't give. If someone just has high blood pressure, but it's well controlled, we still could consider. High cholesterol, typically not a reason we cannot give if it's just high cholesterol, because they shouldn't affect cholesterol and they shouldn't increase cholesterol in any way. But if you have other heart conditions, there may be instances where we really shouldn't use those because it could further increase risk.
Thank you very much. Somebody's asking about vitamins and supplementation with vitamins. Is that recommended as part
Yeah,
of an overall strategy?
it's a great question. We actually just had a discussion on this. It's a whole nother probably 5 to 6 talks on its own. But what I would say, we know that the vitamin supplement arena it's very, very large and it's growing. Um, I think especially in the oncology world, we know that anyone that's been diagnosed or has an increased risk, the use is probably higher than the general population. What I would say about vitamin and supplement use, and this is kind of extrapolating from other cancer types because they've looked at certain vitamins such as vitamin E and selenium and vitamin A and supplementing it to either prevent cancer diagnosis or to prevent an outcome during treatment. And so the general guidance is if you don't have a deficiency, there's likely not a huge benefit to vitamins. If you do have a deficiency, we should treat. But if your levels are normal and we give you more, potentially detrimental depending on the vitamin. So I would not recommend it in that case. What's unknown and challenging is a lot of the other non-vitamin supplements, ginger, turmeric, a lot of these other herbs that can potentially have benefit. We don't have a lot of similar studies to say, here's the dose in a supplement, here's what it can and cannot do. The other pieces, supplements give us um, these items in very concentrated amounts. So if anyone cooks with ginger versus taking a capsule, it's just different. We don't always measure the dose when we eat it in food. Same with turmeric or curcumin. So in general, if it's a reputable source, that's one thing we always worry about safety. Two is some of these can interact with chemotherapy and other treatments, traditional treatments for cancer. So that kind of plays into safety. And then three, sometimes we don't know. So I would say, going back in general, if you have a low vitamin, you may need supplementation. If you have normal levels, you probably don't. And then for things that are sort of unknown, just making sure that you run it by someone in regards to considerations for safety. Something I think patients offer to me because of this arena in terms of what they are taking. I know it's not always shared because different practitioners view supplements differently, but I think the better approach is at least present it. It doesn't mean that one of your doctors may agree with it, but I think safety kind of being at the forefront is most important.
Thank you. That all makes a lot of sense. Thank you. Um, Please discuss these drugs as they relate to decreasing belly fat in particular.
Sorry, can you say that one more time?
Somebody's asking if you could discuss these drugs as they relate to decreasing belly fat in particular.
Great question. Typically, with any degree of weight loss, everyone loses it in slightly different areas and different speed. In general, we think that what we call the intra-abdominal or fat around our organs, typically that is lost first. So we may not see initial weight loss from the outside. After that, it's a little bit different. So some people might lose it from their abdominal area or extremities or their face or a combination of those. The newer injection medications, one of the ways that it's thought they may work is how our body stores and breaks down fat. And so there may be a separate mechanism of action in regard to how it may affect that storing and breaking down fat. So maybe not specifically to the abdominal area. So what I usually say, we can't always target that specific area, but because we see a lot of fat deposit there and then in and around our organs, a lot of which are in that area, we tend to see at least some degree that's lost there. But strictly from the medication perspective, we can't target it based on this medication will preferentially lead to loss in that area.
Thank you. We have a number of questions about BMI. If you're overweight but not obese, how much is your risk of recurrence elevated? Somebody else asked if they were of normal weight but want to prevent recurrence, should they consider a weight loss drug? So I think just generally, um, in terms of BMI, where would you look? At what level would you start thinking about the weight loss drugs?
Yeah, and it's a really good question. And the best measure of excess fat is we do body composition measurements sometimes. And so that some of you may have those scales at home where you step on, and it actually kind of passes a light current, around our body to measure how quickly or slowly that goes through different tissue types. So excess body fat is kind of the more important, that may or may not correlate with body mass index. And so I think we always take body mass index with a grain of salt. The associations that they saw started with over 25, but it was, I wouldn't say a very strong association. So maybe slightly increased risk, but within the error rate, if you're at 26.5, I wouldn't worry too much. I don't want to say that that's for everyone, but we know that 26.5 versus 31, there's a stronger association. So with each kind of point or couple points, that association has become stronger. So if depending on who you see, we always try to do body composition. That's a better measure. If someone has a body mass index 26, but normal body fat, I'm not, I wouldn't do anything in terms of medication for weight loss, because we need to get that into a normal range.
Okay,
Yeah.
thank you. This was a very interesting question that was pre-submitted. For a postmenopausal woman that had uterine cancer, is use of natural progesterone or other hormones contraindicated?
Good question. Depends. I think a lot of the scenarios where it is used are for potentially menopausal symptoms, or there are other scenarios where it's used. So depending on the indication for use, different cancer types might have different receptors. So estrogen receptors, progesterone receptors, we see that a lot, the different combination in breast cancer as well. And so it kind of depends. Supplements, well, not supplements, medications that further activate those receptors, potentially we don't want to give on their own. So we probably wouldn't give estrogen medication, or we might give the combination or progesterone alone. Estrogen in food is another consideration. We get the question about soy a lot, and soy or plant estrogen doesn't activate our body's receptors in the same way. So even estrogen positive breast cancer, for example, eating soy doesn't necessarily increase the risk of recurrence. So what I would say is the estrogen or progesterone medication or supplement potentially should not be used depending on your characteristics of the cancer type and the subtype. So I think definitely something to kind of be aware of, that there are scenarios we shouldn't use them.
Thank you very much. I did have one final question, um, which is, and I know you talked about this and it was on your final slide, but what are your biggest takeaways for patients from this presentation? If you had to sum it up into uh, something people can take away.
Yeah, I would hopefully when you're navigating all of this, because there is a lot of information, and not to say that I or we know anything and everything. I think there's so much information out there. It is hard to navigate, especially when we take news articles, which, like with everything, there needs to be headlines to kind of catch a reader's attention. Navigating that versus maybe what the studies show, and then when we look at studies, how does that actually apply day to day to you and the next person? So what I would say is, with all of this, like you guys are doing, and again, I'm glad that you invited me to speak. I think talking with some of your practitioners, your doctors about this and asking these same questions, because I can give you some general information, and some hopefully applies to some of you in various ways, but ultimately it really does depend on your individual medical history and characteristics, your family history, other medications you're on, what dietary pattern you eat, what activity you do. So there are a lot of different variables that go into this, and many others we didn't even talk about, sleep and stress and uh, smoking. So a lot of different factors that ideally we tailor them into your specific situation that will be most beneficial for you. It's not, doesn't mean it's perfect where we can take your characteristics and tailor it perfectly. But what I would say is doing what you're doing, asking the questions. It is hard to navigate even for people that don't do weight management. So ask the questions, have the discussions. If you're unsure, ask more questions. And like I tell everyone, because we're all different, what works for one person doesn't work for the next, and vice versa. So if you are doing well with weight loss, great, keep it up. If you're not, doesn't mean you're doing something wrong. It just means it needs to be adjusted a little bit.
Thank you very much. It's wonderful that there's a specialty like yours to really work with people in an individualized way and really help them with these issues. So we really appreciate your taking the time. This was really interesting and informative. And thanks to all of those who participated with questions and joined us tonight. Um, Please make sure to check out Share's upcoming educational programs and support groups, and follow us on social media as well. I also wanted to mention, since it's apropos to tonight's topic, that we share partners with INA, which is an app which is called Intelligent Nutrition Assistance. And once you sign up, it's totally free. You can communicate with INA 24/7 to receive personalized, clinically appropriate, and on-demand nutrition support and guidance. So I encourage you to check it out. It's really a terrific app, and the URL is listed on the slide now. So thank you again, Dr. Garcia, and thank you to everyone for joining, and have a good rest of the evening.
Thanks, everyone. Take care.